Hi guys. I was paired up with an outpatient neuro occupational therapist, and my OT has been an OT for over 10 years now, and she's worked in a variety of different settings, such as the ICU, NICU, inpatient care, outpatient care, and acute care. And one of the biggest questions I had for someone who's been in so many different settings is how is the transition going from one setting to a different one? And she says it really depends on the setting. There is always an adjustment period, but you still, no matter if the demographics change, if the clients change, the setting changes, you're still treating everyone with an OT lens. So that stays consistent. But getting used to the setting, there's always like a 6 month to a year adjustment period. For example, her first setting right after school was adult acute care. So she went from adult acute care to the NICU. She said that was a huge adjustment going from handling normal adults, regular adults, to medically fragile babies. And one of her colleagues in the ICU moved from the ICU to the school-based setting, and she said that was a really big adjustment as well. But it's all what you get used to, and you're still treating everyone with that same OT lens. And one of my biggest questions for her as well was, what's it like working in the NICU? Because just recently I heard about the integration of OT into the NICU, and I was like, what does that look like? She said she mainly worked with drug addicted babies, so babies who were addicted to drugs straight from birth, and working on withdrawals, helping them with the withdrawal period. So that could be with deep pressure therapy by wrapping them super tight, just holding the babies and just comforting them through that withdrawal period. And just like passing the babies to nurses and volunteers, just like, hey, this baby might need some more TLC because of the withdrawal. Um, for preemies, it was just gradually exposing them to sensory things and um, teaching them soothing techniques like mouth to hand, and also making sure they hit milestones. So, and also like practicing tummy time and just helping parents feel comfortable as well handling their medically fragile baby. She did say that the NICU was the most intense place she has worked because not only are you working with medically fragile babies, she also had to get extensive training and a bunch of certifications to even be in the NICU. And she had to be under another OT before she could practice by herself for 6 months. And she also said that the nurses were very protective of the babies. So you're like, why are you here? She's like, I'm the OT, I'm here to help. But the nurses were very protective of their babies. Um, she said, so that was all in Indianapolis. And then she moved to Colorado. When she moved to Colorado, she was in the ICU. And this goes into advocacy because I'm like, where, and your time, where have you advocated? Has it been for yourself? Has it been for patients? Where have you mainly like advocated? And she's like, it's been for me and like my OT services. So when she moved from Indianapolis to Colorado to the ICU, her and PTs had like the OTs and the PTs had advocate to the board directors of that hospital of why their services were necessary. Because the hospital was trying to push PT and OT out of the ICU because they're like, you guys, like your guys, you guys' services don't do anything. So they had to do a bunch of research and put together a presentation on why their services were necessary for the ICU. It got through and stuff, but she's like, it was very tedious. She's like, that was 13 years ago. People really didn't know what OT was, but it's gotten better. But it's still, there's certain people in certain settings that don't really know how OT services can help in their setting. So she's like, that is one thing to keep your eye out for. And then I was asking her about her outpatient setting where she's at right now. I was like, what do your assessments look like? She says it really depends on what the goals are and what the diagnoses are of the patients. And she said for upper extremity, some of the assessments they do are box and block, 9-hole peg, grip strength, pinch strength, and 2-point discrimination. For stroke patients, they also do field and they do vagal nerves. They have a vagal nerve simulator, which is really cool. Um, and they also do a lot of driving assessments. So like gas and brake simulators and field of view simulators. Um, and for interventions, I'm like, what kind of intervention types do you do? She's like, in the outpatient setting, we mainly work on restore and modify. So for restore, it's mainly regaining strength, coordination, neuroplasticity, and for modify, just adaptive strategies, energy conservation, and one-handed techniques, as well as working with splinting and adaptive equipment. Um, she's like, I do some splinting, but she's like, one perk of working in the hospital is if like the case is too much or it's something I haven't seen before, I can just pass them to the hand therapist or I can give them to another specialty. And she says she learns a lot from the hand therapist and splinting. She's like, you're never done learning. You always learn something new from other specialties, your patients, and whatnot. So she's like, that's another perk of working in the hospital is how much resources you have. She's very nice. And a lot of what she does is neuroplasticity and making sure that her patients don't lose the skills that their injuries have stopped them from using. And she says rehab is hard, but making it fun increases engagement and, and reduces resistance. Like one of the things she told me was that people associate play with pediatrics, and that's just not true. She's like, I incorporate plays for every single setting, age, demographic, whatever. She's like, I have like little 75-year-old men who I have like these little suction cup things on the window, and she's like, I have them cross the midline, pull them off, and she's like, when they pull off, they make like a little fart sound, and her patients think it's the funniest thing ever. So she's like, play can be in any setting with any age group. And I asked about note taking, and she said she's been very fortunate with all the settings she's been in and all the hospitals she's been to that they use like the same system, so note taking isn't terrible. Like it hasn't been a big switch up. And yeah, so it's the same system. Another thing she said was we were talking about adaptive equipment and home modification stuff. And she mentioned that there's a giant house in Inglewood that has all the home modification equipment you could think of, such as like any kind of chair lift you could think of, bathroom modification, kitchen modifications. She said it was in Inglewood. And I'm like, that sounds pretty cool. I want to go there. We were also talking about burnout. She said it is very setting dependent. She said in acute care, burnout was very common, and yeah, it was just very common because you had a lot of patients who were like, I don't want to do my therapy. This is dumb. I blah blah blah. She's like, it was very wearing on her. But she's the outpatient on the other hand, there's less burnout or you burn out at a less frequent rate because people are more willing to do therapy services, and she feels like she just has more support in outpatient. And I asked her if you could tell your OT student self one thing, what would it be? And she's like, I really wish I got my doctorate because she's like, I work with a bunch of research students and researchers, and she's like, I just love their work and I just love seeing what they do. And she said, I also like, there's been an itch where I want to teach, but she's like, I don't have my doctorate, so I can't really teach. She's like, I wouldn't go back now and get my doctorate. But she's like, if I could, if I could go back, I would get my doctorate so I can do research and teach. So she's like, and the doctorate just gives you more options. Um, man, 10 minutes goes by fast. Yeah, that's what I learned from my OT. Bye.